everybody, Dr. Ryan here, board certified specialist internist. Today we're just breaking down a very fitting diagnosis. We're going to be talking about the 40 causes of seizures and do a quick fire approach to management of status epilepticus. If you haven't yet subscribed to my channel, what's stopping you? Let's go. Seizures. Okay, so seizures broadly are categorized into unprovoked versus provoked flavors. 8 causes of unprovoked, 32 causes of provoked. After unprovoked, we have epilepsy. So epilepsy is basically a tendency to repetitive seizures and where there's no underlying etiology. Okay, so this divided into focal and generalized, and then provoked seizures are further stratified into infectious, toxic, vascular, metabolic, and structural issues. So under focal epilepsy, we're talking about simple or complex, and how you differentiate simple from complex is whether consciousness is preserved or not. In a simple seizure, consciousness is preserved. In a complex seizure, it is not. Then generalized basically has to do with the characteristics of the seizure. We talk about absence seizures, myoclonic, then there's a tonic, and then there's a clonic, and then there's the atonic, and then there's a grand mal. Another word for grand mal is tonic-clonic seizures. Okay, so there's a phase of tonicity when the patient is very stiff. That's the tonic phase, and the clonic phase is where there's repetitive jerky movements. All right, so provoked seizures by and large are divided into infectious etiologies. Now we think about meningitis, encephalitis. A brain abscess is the underlying toxoplasmosis, usually in somebody who's immunocompromised. Is there pneumocystis on board? Is there progressive multifocal leukoencephalopathy, PML? Toxic causes include alcohol. So alcohol can cause seizures on the basis of alcohol intoxication or alcohol withdrawal, right? Then medications can cause it, recreationals and poisons, all right? Vascular causes is a whole truckload here. Stroke, very important. Post-infarct seizures, quite common. Hypertension induced, especially hypertensive encephalopathy, can present with seizures. Intracranial hemorrhage, cerebral venous thrombosis, especially sagittal sinus thrombosis. Congenital vascular malformation, aneurysm, yes, especially berry aneurysms in patients who have adults, autosomal dominant polycystic kidney disease. Vasculitis, reversible cerebral vascular syndrome, or PRES, posterior reversible encephalopathy syndrome, and moya, the so-called puff of smoke that you see on imaging, right? Metabolic causes, there's a whole lot, guys. Hypo and hyperglycemia, hypo and hypernatremia, hypomagnesemia, hypocalcemia, cerebral hypoxia, uremia in the setting of kidney failure, liver failure, eclampsia, and porphyria. And the 2 structural causes are tumor and traumatic brain injury. There's a quick fire approach to managing status epilepticus. Thank you so much to emergencymedicinecases.com for this. So a patient comes in with status epilepticus, right? Now status epilepticus, we know, is defined by repetitive seizures, one after the other for at least 5 minutes, or you can have a seizure and then there's no recovery of consciousness between this and the next, right? So A, B, C, D, E, F, G, first year, airway, breathing, circulation. Don't ever forget the glucose. So you got to check your glucose. Ensure the patient's airway is attended to. Put them in the lateral decubitus position. Nasal trumpets, oxygen and suction if the patient's hypoxic and you're on a suction if appropriate. IV access, this is most important. And then concurrently search for a reversible cause. Within 0 to 5 minutes of presentation, you want to use a first-line agent. For instance, you can use Ativan, which is lorazepam. The dose is 0.1 milligram per kg IV, max of 4 milligrams. Repeat once in 4 minutes. Or you can go Domicum, which is midazolam, 10 milligrams. IV is where we go. Excuse me. Then within 10 to 15 minutes, if that doesn't work, your second-line agents are levetiracetam, phenytoin, or valproate, and those are appropriate doses. At the same time, you want to instigate or help with advanced airway management. So rapid sequence intubation, pre-oxygenate with a bag valve mask, and then you can use an induction agent like propofol, also called ketofol, which is ketamine propofol. Right, paralytics with rock or saxamethonium, right? And then if it's still refractory, then you have to go and intubate the patient and mechanically ventilate the patient. And these are the agents we use for anesthesia. Propofol, you can use midazolam infusion, ketamine, phenobarb, etc. God bless you guys. Thank you so much. I will catch you soon with another high impact, high yield internal medicine topic on my channel. God bless you.